Welcome to the weekly neurology deep dive.
Yes, and before we begin, just a quick reminder that this audio program is strictly for educational purposes. It has no commercial goal, and, well, it is only a summary.
Right, absolutely. We highly recommend you read the full paper we are discussing today.
Exactly. And today we are reviewing the paper titled Comprehensive Review of West Nile Virus: Transmission, Epidemiology, Prevention, Clinical Manifestations, and Advanced Diagnostic Frameworks.
So to start us off, let us just provide a direct, practical summary of the data for you, the busy neurologist listening.
Good idea. So, West Nile virus typically causes asymptomatic infection in about 70 to 80% of cases.
Right. And then systemic West Nile fever occurs in about 20% of cases.
Exactly. And the severe West Nile neuroinvasive disease happens in below 1% of cases.
Wow, okay. And for diagnosis, the standard is cerebrospinal fluid, immunoglobulin M capture, enzyme-linked immunosorbent assay, right?
Yes, that is the definitive standard. And for diagnostic imaging, that is best achieved with MRI, which typically shows deep gray matter hyperintensities.
And if you're doing electrophysiology, electromyography confirms anterior horn cell destruction while strictly sparing the sensory nerves.
Right. And in terms of therapeutics, unfortunately, there are no approved targeted antiviral therapies.
Yeah, and even the clinical trials for IVIG show results that are not significant, which we will get into.
Which means management relies entirely on neurosupportive optimization.
So let us dive right into the transmission dynamics, because the clinical presentation you observe in the hospital, it directly results from this highly specific vector-host amplification loop, right?
Exactly. The virus operates within an ecological cycle that is strictly dependent on Culex mosquitoes and avian reservoirs.
And different mosquito species drive this transmission depending on the environment.
Yeah, I mean, Culex pipiens dominates the urbanized ecosystems in the northeastern United States and eastern Canada.
While Culex tarsalis is the highly competent vector across the western agricultural landscapes, right?
Right, and then you have Culex quinquefasciatus, which propagates transmission across the southern subtropical corridors.
But the host competence, specifically within that avian reservoir, that requires the birds to sustain a really high titer systemic viremia, doesn't it?
Yes, for several consecutive days. That high viral concentration is strictly necessary to successfully infect a naive feeding mosquito.
And birds from the family Corvidae exhibit extreme susceptibility to this viral replication.
They do. They frequently develop fatal systemic infections while serving as the primary amplification engine.
Which brings us to humans, because humans and other non-avian mammals function entirely as dead-end hosts.
Right, and that is a striking biological irony, because the virus successfully breaches the mammalian blood-brain barrier to cause devastating neuroinflammatory tissue damage.
But the subsequent systemic human viremia remains extremely low titer and transient.
Exactly. The viral concentration in human peripheral blood remains entirely below the threshold required to infect a mechanical Culex vector during a subsequent blood meal.
So it destroys the human nervous system, but it cannot utilize the human host for further ecological propagation.
Precisely. Now, alternative transmission routes do exist, and those require strict clinical vigilance from you.
Right, like blood transfusions. Those carry a documented risk, which mandates universal nucleic acid testing screens of the blood supply during active transmission seasons.
Yeah, and vertical transmission also occurs through transplacental intrauterine migration, which causes congenital infection, alongside documented postpartum transmission through breast milk.
Wow. And we also have to think about occupational inoculations, right?
Absolutely. Those pose severe risks for laboratory technicians and healthcare workers who handle and process highly infectious clinical cerebrospinal fluid isolates.
Geographically speaking, lineage 1 dominates the North American continent. But let us talk about the timeline. The clinical apex of human infection occurs precisely between late July and early September.
Right, and the reason for that is mosquitoes function as ectothermic organisms.
So the elevated ambient heat directly dictates the extrinsic incubation period.
Exactly. That is the exact time span required for the virus to replicate within the mosquito midgut, penetrate the hemicole, and migrate to the salivary glands.
And elevated ambient heat severely compresses that extrinsic incubation period.
Yes, which exponentially increases the transmission velocity during those late summer months.
So I have to ask, how does this dead-end host biological mechanism directly impact the sensitivity of serum molecular testing in the acute clinical setting? Because by the time you are consulted for a patient presenting with altered mental status, the peripheral viral load has likely shifted significantly.
That is a critical point. The low-titer systemic viremia directly and severely limits the efficacy of peripheral molecular diagnostics.
So the reverse transcriptase polymerase chain reaction testing performed on peripheral blood serum.
While it yields a clinical sensitivity below 20% by the time overt neurological symptoms prompt an emergency department evaluation.
Below 20%, that is really low.
Right. Because the human innate immune system neutralizes and clears the peripheral viral load extremely rapidly.
Leaving an insufficient concentration of circulating ribonucleic acid particles for standard serum molecular detection.
Exactly. So this biological reality dictates your entire diagnostic workflow. You cannot rely on peripheral blood analysis to rule out the infection. You must rely entirely on intravesical serological testing to identify the central nervous system invasion.
Okay, that makes sense. So following this viral breach of the blood-brain barrier, let us transition directly into the specific neurological syndromes this invasion produces.
Right. We need to clearly delineate the protracted systemic debility of West Nile fever from the really devastating presentations of West Nile neuroinvasive disease.
So West Nile fever occurs in about 20% of infected individuals following the initial incubation period.
Yeah. Patients present with an abrupt onset of high-remittent fever, severe frontal or retroorbital headache, generalized myalgias, arthralgias, profound asthenia, and anorexia.
And a rash, right? A non-pruritic erythematous maculopapular rash develops in about 50% of symptomatic patients.
Right. And that specific dermatological finding originates on the trunk and chest before spreading centrifugally to the extremities.
But strictly and completely sparing the palms and soles.
Exactly. And, severe lethargy, marked fatigue, and cognitive slowing frequently persist for several months following the resolution of the acute viremia.
Then we have West Nile neuroinvasive disease, which presents clinically as 3 primary phenotypes. Let us break those down. First, West Nile meningitis.
Right, which accounts for about 30 to 40% of neuroinvasive cases. Patients present with high fever, severe headache, photophobia, phonophobia, and objective physical signs of severe meningeal irritation.
So at the bedside, your examination will reveal distinct nuchal rigidity, a positive Kernig sign, and a positive Brzezinski sign.
Exactly. But crucially, the viral inflammation remains confined to the subarachnoid space and meninges.
Meaning the cerebral parenchyma is strictly spared.
Yes, leaving patients completely oriented, lucid, and entirely free of focal neurological deficits.
Okay, contrasting that with West Nile encephalitis, which represents a severe, direct parenchymal brain infection.
Right. These patients display a rapidly altered sensorium ranging from mild cognitive confusion to progressive spatial disorientation, profound lethargy, severe delirium, combative neuropsychiatric agitation, and eventual stupor.
And focal neurological deficits frequently accompany this global encephalopathy, right? Like acute central facial nerve palsies, dysarthria, expressive receptive aphasia, and hemiparesis.
Exactly. And then the third phenotype is West Nile acute flaccid myelitis.
Which is a terrifying polio-like syndrome.
It really is. It is caused by direct viral targeting and destruction of the motor neurons located within the anterior horn of the spinal cord.
So patients present with a remarkably rapid onset of asymmetric flaccid paralysis developing over mere hours.
Yeah, and there is a severe and immediate risk for the viral replication process to ascend directly into the lower brainstem.
Causing bulbar palsy.
Right, which manifests clinically by sudden dysphagia and vocal cord paralysis.
And consequent involvement of the phrenic nerve nucleus leads to sudden catastrophic diaphragmatic failure, requiring emergent endotracheal intubation and mechanical ventilation. But wait, I need you to clarify something here. Detail the exact physiological and anatomical sparing within the spinal cord that allows a patient to present with profound, rapid flaccid paralysis while maintaining entirely intact pathways for standard touch, pain, and temperature sensation in acute flaccid myelitis.
It is fascinating, really. The virus exhibits a highly specific absolute tropism for the efferent lower motor neurons situated exclusively within the anterior horns of the spinal cord gray matter.
So the viral cellular entry receptors and subsequent intracellular replication machinery completely ignore the afferent sensory structures.
Precisely. The dorsal root ganglia, the posterior columns mediating proprioception, and the anterolateral spinothalamic tracts mediating nociception and temperature remain structurally and functionally untouched by the viral replication process.
Wow, okay. So afferent somatosensory action potentials just travel unimpeded through these preserved posterior and lateral ascending pathways to the somatosensory cortex.
Exactly. Consequently, when you examine the patient, you observe profound asymmetric motor paralysis and severe aplexia, while the patient retains completely intact and objective standard touch, pain, and temperature sensation across the paralyzed dermatomes.
That is such a key localization point. Because the virus targets specific central nervous system structures, we must connect these clinical phenotypes to the distinct, localizing physical signs observed during the neurological examination.
Right. And the virus exhibits a marked, aggressive tropism for the deep gray matter structures of the brain, particularly the substantia nigra and the lentiform nuclei of the basal ganglia.
And this precise anatomical affinity produces highly objective basal ganglia signs during the acute phase of encephalitis.
Yes. For instance, the West Nile tremor manifests clinically as a prominent, coarse, postural, or kinetic action tremor that primarily affects the upper extremities.
And encephalitic patients consistently display asymmetric myoclonus, severe global bradykinesia, profound facial masking, and classical cogwheel rigidity upon your passive joint manipulation.
Right. Ambulatory encephalitic patients also demonstrate marked retropulsion and a highly unstable festinating, shuffling gait.
And then there are the cranial neuropathies, which emerge directly from viral inflammation and cellular destruction involving the distinct cranial nerve nuclei distributed along the brainstem axis.
Exactly. Patients frequently present with ophthalmoplegia, causing objective strabismus and diplopia, consistently paired with multidirectional horizontal or vertical nystagmus.
Facial diplegia is also seen, right?
Yes, it manifests as a severe, highly asymmetric lower motor neuron facial weakness involving both the upper and lower quadrants of the face, clearly differentiating it from a central pyramidal lesion.
And the virus can also trigger opsoclonus myoclonus syndrome, producing rapid, involuntary, chaotic, multidirectional conjugate ocular movements occurring simultaneously with severe systemic myoclonus.
Exactly. Now, reflex status alterations provide you with precise anatomical localization during the acute phase, too.
Right. Arflexia, or severe hyperreflexia, occurs exclusively in limbs affected by acute flaccid myelitis, definitively indicating lower motor neuron anterior horn destruction.
Conversely, objective hyperreflexia, sustained ankle clonus, and positive Babinski signs indicate severe upper motor neuron pyramidal tract damage resulting from the widespread cortical and subcortical inflammation of severe encephalitis.
So let me challenge you on something. How do you clinically differentiate the rapid ascending paralysis of West Nile flaccid myelitis from severe Guillain-Barré syndrome, strictly based on physical examination findings at the bedside?
Well, the absolute preservation of objective sensory functions serves as your primary and most reliable bedside differentiating feature.
Because Guillain-Barré syndrome represents a post-infectious, immune-mediated, demyelinating polyradicular neuropathy that involves peripheral sensory nerve fibers.
Exactly. Guillain-Barré syndrome frequently produces objective distal sensory loss or prominent ascending distal paresthesias.
Whereas West Nile, acute flaccid myelitis, strictly and entirely preserves objective sensory function due to that isolated anterior horn tropism.
Right. Furthermore, West Nile acute flaccid myelitis typically presents with a highly asymmetric, patchy pattern of profound flaccid weakness depending on which specific anterior horn segments are undergoing active viral destruction.
And Guillain-Barré syndrome classically presents as a highly symmetric, bilateral ascending paralysis.
Yes. Also, the concurrent presence of any central extrapyramidal signs, including the coarse postural tremor, asymmetric myoclonus, or altered mental status, localizes the pathology definitively to the central nervous system.
So identifying these upper motor neuron or basal ganglia signs instantaneously rules out a pure peripheral neuropathy like Guillain-Barré syndrome.
Yeah, exactly.
All right, so once you identify these localizing signs, we transition to the advanced diagnostic framework required to confirm the etiology.
Right. As we established, peripheral blood reverse transcriptase polymerase chain reaction has an unacceptably low clinical sensitivity, frequently falling below 20%.
So the definitive diagnostic standard is the cerebrospinal fluid immunoglobulin M capture enzyme-linked immunosorbent assay.
Yes, the objective presence of immunoglobulin M antibodies within the cerebrospinal fluid confirms active intraphagical antibody synthesis occurring in direct response to the central nervous system viral invasion.
But you must rule out serological cross-reactivity using a specialized plaque reduction neutralization test for any patient presenting with a prior history of yellow fever vaccination, previous dengue virus exposure, or recent tick-borne flavivirus exposure, right?
Exactly. The flavivirus genus shares highly conserved envelope protein epitopes, which frequently trigger false positive immunoglobulin M results on standard assays.
And the routine cerebrospinal fluid analysis consistently reveals marked hyperproteinuria, with total protein levels typically elevated between 50 and 150 milligrams per deciliter.
Crucially, though, the cerebrospinal fluid to serum glucose ratio remains strictly and entirely normal.
And diagnostic imaging relies exclusively on MRI, as standard CT scans of the brain and spine remain completely normal and lack the tissue resolution required to detect the viral inflammatory changes.
Right. T2-weighted, fluid-attenuated inversion recovery and diffusion-weighted imaging sequences reveal highly abnormal bilateral hyperintensities localized precisely in the thalami, the globus pallidus, the substantia nigra, and the red nuclei of the midbrain.
You may also observe prominent leptomeningeal enhancement alongside focal signal abnormalities extending descendingly into the pons and the medulla oblongata.
And sagittal and axial MRI views of the spinal cord in patients presenting with acute flaccid paralysis frequently show focal T2 and fluid-attenuated inversion recovery hyperintensities centered precisely within the anterior horns of the cervical or lumbar cord enlargements.
Electrophysiological testing also definitively differentiates viral myelitis from acute peripheral neuropathies.
Right. Nerve conduction studies of the affected motor pathways show markedly reduced compound muscle action potential amplitudes, physically confirming the acute loss of functional motor axons undergoing Wallerian degeneration.
While the sensory nerve action, potential amplitudes, and conduction latencies remain strictly normal, validating the structural integrity of the dorsal root ganglia.
Exactly. And needle EMG confirms widespread, active spontaneous denervation potentials within the affected musculature.
So you will observe acute fibrillations and positive sharp waves, directly validating the active, irreversible, and destructive degeneration of the anterior horn cells. But I have a question about the exact timing of your lumbar puncture because it complicates this diagnostic framework. Why can early cerebrospinal fluid cell counts be deceptive and mimic a bacterial etiology in the first 24 to 48 hours?
That is a great question. The initial physical penetration of the central nervous system by the virus triggers an overwhelming and immediate acute inflammatory cytokine response.
So a massive inflammatory cascade.
Right. And this causes an immediate aggressive influx of polymorphonuclear leukocytes directly across the blood-brain barrier and into the subarachnoid space.
So this early rapid cellular migration produces a severe neutrophilic predominance within the cerebrospinal fluid pleocytosis during the critical first 24 to 48 hours.
Exactly. This transient, highly neutrophilic cellular pattern frequently deceives frontline clinicians into incorrectly suspecting a primary bacterial meningitis.
And the cerebrospinal fluid cellular profile transitions to the classically expected viral lymphocytic predominance only after this initial hyperacute phase resolves.
Which is exactly why identifying the strictly normal cerebrospinal fluid to serum glucose ratio remains absolutely critical for you to accurately rule out a consumptive bacterial etiology during this specific, highly deceptive early temporal window.
Okay, that is incredibly helpful. So concluding the clinical workflow, we have to connect the confirmed diagnostic findings to patient management, prognostic expectations, and counseling.
Right. And we have to reiterate, there are currently no targeted antiviral small molecules or specific monoclonal antibodies approved by regulatory agencies for the direct treatment of West Nile virus.
So your clinical management must rely entirely on aggressive, intensive supportive care.
Yes. Severe encephalitis cases require continuous neurointensive monitoring explicitly focused on maintaining adequate cerebral perfusion pressure, aggressively managing widespread neuroinflammation, and immediately utilizing intravenous anticonvulsants to suppress secondary cortical seizures.
And neuromuscular respiratory support in patients with flaccid myelitis requires strict, continuous bedside monitoring of the forced vital capacity and the negative inspiratory force.
Exactly. Early endotracheal intubation and mechanical ventilation are definitively indicated if the forced vital capacity drops below 15 to 20 milliliters per kilogram, or if emerging bulbar signs create an immediate life-threatening aspiration risk.
Now, what about investigational therapies? High-dose IVIG has been used empirically, hasn't it?
It has. Specifically, IVIG derived from pooled plasma donors residing in highly endemic areas with the theoretical goal of providing neutralizing antibodies.
But large clinical trials have consistently failed to show a significant reduction in patient mortality or long-term neurological disability using IVIG.
Right. The results are not significant, and interferon alpha administration has not demonstrated a clear, objective clinical benefit in properly controlled patient cohorts either.
And routine systemic corticosteroid use is strongly discouraged due to the documented potential for profound inhibition of the patient's innate viral clearance mechanisms.
Precisely. Let us look at the prognosis. The acute mortality rate for neuroinvasive disease ranges between about 4 to 14%.
But that mortality rate climbs severely to over 20% in patients older than 70, or those currently undergoing therapeutic pharmacological immunosuppression for organ transplantation or rheumatological conditions, right?
Right. Yes, it does. And the long-term prognosis depends heavily and specifically on the exact clinical phenotype.
West Nile meningitis generally carries a highly favorable prognosis, with the vast majority of patients achieving complete baseline neurological recovery within several weeks of symptom onset.
However, West Nile encephalitis is consistently associated with highly prolonged, complex cognitive recovery.
Right, a significant proportion of encephalitic survivors experience severe, persistent cognitive deficits, profound memory loss, clinical depression, and residual motor ataxia, persisting up to a full year after initial hospital discharge.
And West Nile, acute flaccid myelitis carries the highest absolute risk for permanent, devastating structural disability.
Because the motor neurons destroyed by the intracellular viral replication do not regenerate.
Exactly. Most afflicted patients experience permanent, severe, asymmetric motor deficits, progressive, profound muscle atrophy, and highly restrictive long-term functional impairment, necessitating early, aggressive, intensive physical therapy and specialized neurorehabilitation to maximize residual biomechanical function.
We should also take a moment to debunk some clinical myths, because medical misconceptions frequently complicate broad public health communications and delay accurate clinical triage.
Yes, there is a highly prevalent and dangerous clinical myth that suggests West Nile acute flaccid myelitis strictly and exclusively affects the elderly or individuals who are already severely immunocompromised.
Which is absolutely not true. West Nile acute flaccid myelitis frequently occurs in young, entirely immunocompetent individuals with absolutely no pre-existing health conditions, leading directly to sudden, severe, and permanent paralysis.
Exactly. Another widespread misconception asserts that the virus can be transmitted directly from person to person through environmental exposure.
Right, but transmission strictly requires an active arthropod vector inoculation or a direct fluid introduction via screened blood transfusion or solid organ transplantation.
The virus simply cannot be transmitted through casual environmental contact, aerosolized respiratory droplets, or direct skin-to-skin contact.
I do want to push back on one assumption, though. The epidemiology frequently leads to medical misconceptions, particularly the assumption that living in an endemic geographic region translates to a uniformly high risk of developing these severe neurological phenotypes. Can you clarify the actual statistical probability of a local mosquito carrying the virus and successfully transmitting neuroinvasive disease to a human host?
It is an important point. The objective statistical probability of human exposure and subsequent neuroinvasion remains mathematically minimal even in highly endemic zones.
Really? How minimal?
Fewer than 1% of all tested mosquitoes in an active endemic area actually carry the virus within their salivary glands, even during the peak of a high-transmission summer season.
And among the specific individuals bitten by an infected competent mosquito, about 70 to 80% clear the viral particles entirely asymptomatically through innate immune mechanisms without ever developing clinical symptoms.
Exactly. Because human systemic infection rarely breaches the highly selective central nervous system barriers, the actual statistical probability of any given patient developing overt neuroinvasive disease from a given mosquito bite remains definitively below 0.01.
Okay, that is crucial context. So, to synthesize the primary actionable takeaways for daily clinical practice, we will repeat the exact actionable summary provided at the beginning of the program.
Right. West Nile virus typically causes asymptomatic infection in about 70 to 80% of cases, systemic West Nile fever in about 20% of cases, and West Nile neuroinvasive disease in below 1% of cases.
The diagnostic standard is cerebrospinal fluid immunoglobulin M capture enzyme-linked immunosorbent assay.
And diagnostic imaging is best achieved with MRI showing deep gray matter hyperintensities.
Electromyography confirms anterior horn cell destruction while sparing sensory nerves.
And remember, there are no approved targeted antiviral therapies. Clinical trials for IVIG show results that are not significant.
So clinical management relies entirely on neurosupportive optimization.
Yes, exactly.
To leave you with a final thought to mull over, with shifting environmental climates actively expanding the habitat of Culex mosquitoes and accelerating viral replication cycles within these vectors, neurologists outside historically recognized endemic zones must now maintain a remarkably high index of clinical suspicion for these severe neuroinvasive phenotypes. Thank you for joining us on this deep dive.